So welcome back. In this video tutorial, we're going to be looking at the different kinds of opioid medications that are commonly used in pain management. And we're also going to be looking at some of the tools available to help identify addiction, tolerance and dependence, and also discussing particular risk factors that individuals may have that may indicate a higher incidence of or a higher likelihood of developing an issue around addiction. So let's start, Dr. McCoy, with tablets, patches and capsules in terms of the different formulations available for opioid medications.
So opioids, as we spoke in the last tutorial, have been around for many, many years. And most of the time they are delivered by tablet out of hospital when a patient is otherwise well and they can use their gastrointestinal tract. If they're in hospital, obviously it has to be used outside of that, so as intramuscular injections, intravenous injections, subcutaneous, etc. The question of what type of opioid to use and what route to use it is really important. In the last 20 years, we can now deliver opioids in almost any route into the body, including being inhaled. Tablets obviously are the forefront and they're the most common way of giving an opioid. We rarely give patients injections to give to themselves or for their family to give them out of hospital, with the exception of cancer pain. We rarely give suppositories in this country, although they are available. So the other method of delivering an opioid other than tablets is by a patch. And this is a way of bypassing the liver where some of metabolism occurs from the drug. And it is a way of delivering it in a smooth, uniform fashion throughout the 24-hour period. There are two agents available on the Australian market for delivering opioids by patch. One is buprenorphine, which is a mixed opioid, so it has some effects of an opioid and some of the effects that go directly against an opioid, a strange mixture. The other is fentanyl, which is a very powerful opioid, probably reserved for cancer pain, but also available as a patch. The methods of delivering them in a very small population can be considered if spinal opioids, in other words, giving the morphine or fentanyl or hydromorphone into the spine is considered. And that is in a very small population, less than 1% of patients with persistent pain would consider that an option. Now, given the dangers that we described in the last tutorial, we have to consider three really important elements. The issue of addiction is of primary importance. We do not want to deliver an agent. We do not want to induce a state in which harm is going to accrue from the medication that we give. Addiction is a biological and psychological overwhelming feeling of having to take a substance or engage in an activity that the patient knows is bad for them. So we talk about alcohol addiction, drug addiction, addiction to gambling, addiction to shopping, things that are going to do harm to the patient, even when it is not indicated. Tolerance is a specific but separate phenomenon. It is requiring more of the agent to get the same effect from the drug in question. We see this with beta blockers, we see it with antibiotics to a certain extent, and we certainly see it with opioids. The next one that I wanted to talk about is dependence. And dependence is a specific entity. An insulin-dependent diabetic is dependent on their insulin to keep their sugars in control. An epileptic may be dependent on their anti-epileptic medication for control of seizures. And similarly, a patient may be dependent on their opioid to effect good analgesia and improve their quality of life. And it is these three things which can overlap. They can coexist in the same patient. So they can be tolerant and dependent. They could be tolerant and addicted. But being dependent does not mean addiction, and they must be separated out. To understand these, a certain amount of study and time must be put into researching how you might assess patients for these. And there are various different questionnaires and tools. There is the universal precautions before opioid prescription, and they're enumerated from 1 to 10. There are opioid risk tools of various different types so that we can stratify the risk, something like a traffic light from green, amber and red, to seeing whether a patient is at low, medium or high risk of becoming addicted. I would draw your attention to an application which is free for download on the Apple system and the Android system, and can be obtained from the App Store or directly from the Faculty of Pain Medicine. It is an opioid equivalence table application, which we can, in a way, artificially work out how many milligrams of one drug is equivalent to how many milligrams of another drug in the opioid family. And we use this in order to minimize the amount of opioid we're exposing the patient to. By and large, we would like to minimize and decrease it below 50 milligrams, or certainly below 80 milligrams of morphine equivalent per day. Now, there are a number of new drugs which have come on the market in the last 5 to 15 years, one being tramadol and the other being tapentadol. They are considered atypical opioids. They have other effects. The incidence of tolerance, addiction and dependence is less, and the danger to the patient is less. They're interesting drugs, and they may have an application in persistent pain long term without as many problems, not without no problems, without as many problems as some of the standard opioids. So opioids, the good, they're excellent analgesic agents, at least in the initial stages. The bad is that they have significant side effects which lead to morbidity and mortality. And the ugly is that not one opioid is useful for all pain states in all patients, and therefore it is an individualized entity. It is the specialist pain medicine physician who, having assessed the patient's pain in terms of their history, their examination and investigations, can select an opioid as part of the overall strategy for managing their pain, improving their function and their quality of life.
Great. And are there any particular risk factors or behavioural patterns that you would identify that would mean you'd be hesitant to prescribe an opioid to an individual despite the pain management requirements?
If the patient has demonstrated substance misuse in the past, be that tobacco, alcohol, or for example, marijuana use, or any other illicit substances, they would probably be considered a higher risk of misusing an opioid. Child sexual abuse, both in men and women, brings in a higher risk, and there are other aspects to the patient's background and their medical history that can help decide whether it is appropriate to use an opioid. Even those who are at high risk may be appropriate for opioid use as a short-term entity, as a short-term strategy. But long-term strategy and long-term planning with opioids is probably unwise and probably not serving the patient very well.
And just in conclusion, before we move on to look at other kinds of drugs that are used commonly in pain medicine, do you have a sense, or could you provide a rough estimate of the frequency of use of opioids, even in the very short-term, early stages of the pain management process? Would it be used very frequently or rarely?
Well, unfortunately, it's used more frequently than we would like. It is understandable that patients coming out of hospital after an acute injury or operation or illness would be provided with analgesia leaving the hospital. But there needs to be a sunset clause in that prescription, and strict instructions and clear instructions to the patient and their treating doctor should be provided so that we can discontinue these medications. So for acute back pain, it may be appropriate to use opioids, but only in the very acute stages. and probably no more than for a number of days, or probably a week at most. And then a multimodal, multidisciplinary, and a wider approach to the management of acute back pain, because opioids are probably quite disappointing in its use. The next problem is that with long-term use, we can run into problems like impacts on their immune system, of osteoporosis, of endocrine effect, and this is particularly acute in men whose testosterone falls quite considerably, even on moderate doses of opioids. And then this new phenomenon that we've realized and taken from the cancer population called opioid-induced hyperalgesia. So this is an increase in pain with increased or high doses of opioids. It's a phenomenon probably of the immune system at central nervous system level, and is quite complex, but one that we see not infrequently.
Fascinating. And as you said right at the start, there's a lot that we still don't know, despite opioids being used for pain relief for centuries. So thank you for that, Dr. McCoy. We're going to move on to look at the other range of medications that are commonly used now in pain management. So I do hope you'll come back.